Chapter 46, Acquired Heart Disease. Acquired heart disease covers all the conditions that were not present at birth. Children with CHD can develop acquired heart disease. Infective endocarditis is inflammation that happens from an infection of the cardiac valve and endocardium. It's typically caused from a bacteria, but it could be viral or fungal in nature. The manifestations vary depending on what organism is the cause, but most common ones will include anorexia, nausea, fatigue, arthralgia, chest pain, petechiae, and neurological impairment. Diagnostic evaluation is done by blood cultures to detect the causative agent, and they will also do an echo. Other lab tests that can help are the CBC, ESR, ECG, and rheumatoid factor. Prevention is the most important therapeutic intervention. Children at risk need optimal dental care. Therapeutic management is if they have infective endocarditis would be high doses of appropriate antibiotics IV for 2 to 8 weeks. So this means they may go home with home care to continue them. Prophylaxis for 1 hour before procedures, or which usually is going to be IV, or they can use PO in some cases. Nursing management will include educating on the signs and symptoms of endocarditis and the need for the prophylaxis antibiotic before invasive procedures or dental work. This is changing, and now they are using this only for very high risk. At least that's a recommendation, but not all providers have changed. Identifying dysrhythmias in childhood is important. They must be quickly identified as life-threatening or non-life-threatening. In tachydysrhythmias and bradydysrhythmias, cardiac output is diminished. They will have low cardiac output, which results in poor organ perfusion. Many times, the early symptoms are subtle, but as a disease progresses, they may become more noticeable. The infant and toddler will show poor feeding, irritability, lethargy, pale, poor peripheral perfusion, decreased urine output, and heart failure. In older children, they can experience palpitations, dizziness, syncope, and exercise intolerance. Diagnostic evaluation is a 12-lead ECG. Therapeutic management includes meds, ablation, cardioversion, and pacemakers. 2 dysrhythmias due to a fast rate include supraventricular tachycardia and ventricular tachycardia. Treatment measures vary, but they must slow down that heart. Dysrhythmias due to a slow rate include bradydysrhythmias and absent rhythms. Surgery is typically needed for bradydysrhythmias, and CPR and medical management is needed for absent rhythm. Epinephrine is the drug of choice. Rheumatic fever is an inflammatory disease occurring after a group A beta hemolytic streptococcal pharyngitis known as GABHS or GABS. Infrequently seen in the United States, it is a big problem in developing countries. It is self-limiting. It affects joints, skin, brain, serous surfaces, and the heart. Major manifestations include carditis, polyarthritis, chorea, erythema margitum, and subcutaneous nodules. Minor manifestations include fever, arthralgia, elevated ESR or positive C-reactive protein, prolonged PR intervals, and supporting evidence of preceding streptococcal infection. Diagnosed by the Jones criteria, which is they have the presence of 2 major manifestations or 1 major manifestation and 2 minor manifestations. Therapeutic management includes prevention of GABS, so you have to think infection control, instruct on the importance of finishing all antibiotics, having a recheck if ordered, educate on the spread of the disease. Penicillin is the drug of choice if they're not allergic. If there's an allergy, then sulfa or erythromycin. If treatment is not effective, then they can repeat. Kawasaki disease is an acute systemic vasculitis of unknown cause. In 75% of the cases, the child's younger than 5 years of age. It has 3 phases. The first is the acute phase, and this is a sudden high fever, unresponsive to antipyretics and antibiotics. The subacute phase lasts from the end of the fever through the end of all Kawasaki disease clinical signs. And the convalescent phase is the clinical signs have resolved, but lab values have not returned to normal. It will end when the normal values have returned, which can take 6 to 8 weeks. Clinical manifestations can include the child must have a fever for more than 5 days, along with 4 of 5 clinical criteria. 1. Changes in the extremities. In the acute phase, edema, erythema of the palms and soles, In the subacute phase, they can have periinguinal desquamination, which is peeling of the hands and feet. 2 is bilateral conjunctival injection, which is inflammation without exudation. 3 is changes in the oral mucous membranes, such as erythema of the lips, oropharyngeal reddening, or what they call strawberry tongue, which is where large papillae are exposed. They can have 4 is polymorphous rash, and 5 is cervical lymphadenopathy. Acute phase symptoms may come and go. The child is usually pretty irritable. During the subacute phase, the child is at highest risk for coronary artery aneurysms. Echocardiogram is used to monitor. Treatment will include, they'll have an intravenous immunoglobulin, IVIG. They will do acetylsalicylic acid, or aspirin, 80 to 100 milligrams per kilogram per day for anti-inflammatory, and then 3 to 5 milligrams per kilogram per day for an antiplatelet. Low-dose aspirin is continued until the platelet count has returned to normal, which can be 6 to 8 weeks. If coronary abnormalities develop, aspirin therapy will be continued indefinitely. You should be familiar with hypertension, so I will just touch on what you need to know for the pediatric population. Many times there's no clinical manifestations of hypertension, but if the blood pressure rises, they can have dizziness, headaches, epistaxis, and visual disturbances. Diagnostic evaluation includes obtaining history and physical exam, which would include blood pressure checks. Therapeutic management includes weight reduction, which should be a healthy lifestyle change and no diet. Physical conditioning, which include 30 to 60 minutes of aerobic exercise several times a week, relaxation techniques, and possibly some pharmacological treatments. Identify kids at risk and treat early for high cholesterol. It's recommended all kids get a cholesterol screening between ages of 9 and 11. Treatment is lifestyle modification and restrict intake of cholesterol and fats. Increase intake of whole grains, fruits, and vegetables. They will exercise for 60 minutes a day, 5 days a week. Stop smoking and avoid secondhand smoke if they were smokers. If there's no response to diet changes and medications, a couple of them that they use is cholestyramine and cholecystramine.